Good Sunday morning, everybody. Should be saying good Sunday afternoon for you folks across the pond. Coming on today to talk about some exercise. We had some good questions posted up there on the discussion page, so we'll be touching upon them at the end. I wanted to go through a little bit of a talk that I've done as part of a course that I do. I just kind of pulled some slide from a lecture that I do both at a university level and a continuing education course level. And kind of go over some things from my thoughts around exercise. Jared's posted some great videos of him and Ben Cormack talking about exercise and more from a strength perspective. That's very worth your time to check that out as well. But let's dig into the presentation and we'll start talking about exercise. For those of you guys who are live, I know I'm just kind of coming on randomly, so if you are able to put some comments on there, I should be able to see this. The software does allow me to see comments and reactions. So if you have questions along the way, throw them up there. Otherwise, let's get rolling. So exercise, and I strike out pain science or the pain of pain science on purpose because it's science. It's not anything special with, pain science. Again, I think that's just a bad term because it kind of cordons this off as some separate intervention or some separate thing we're doing with patients. And it's simply incorporating current science into what we're doing around exercise. I will preface this talk and tell you that I am not a strength and conditioning specialist. I don't get into the nitty-gritty weeds of periodization and crazy amounts of detail like maybe you'll see Scott Morrison on social media, who's a great resource if you ever get a chance to check out Scott. But my population, although I do see some occasional athletes, it's primarily persistent pain, more in the middle to later age set. So I'm going to talk about it maybe from that perspective, but definitely have incorporated this with athletic populations as well. And we'll talk about kind of how I may do that as we kind of roll through things today. So one of the first things I think we need to think about is how we as a profession kind of talk and behave around exercise, because that really translates to our patients when we talk about you can't go wrong getting strong and just lift up heavy shit. And, or if we're in this, other end of the spectrum. And I just had a good discussion with Phil this morning on a mentor call about some of how I used to behave around exercise, with patients with knee OA, for instance. I think I was just as fearful, if not more than the patient. Oh man, I should just stick on the plinth. Let's just do straight leg raises, clams, glute squeezes. None of that crap gets that patient back lifting, coming out of a chair, sit to stand, or going up steps or walking long distances. I wasn't getting them anywhere near a low tolerance with the exercise they're giving them, but it was more out of my fear of this, they have knee OA. And I had this mindset almost of bone on bone and these negative things that we think about with osteoarthritis. So I think we have to really check our language and our behavior on exercise first to make sure are we 100% adaptive, currently science-based, really tailoring it to the patient's mindset and their, and current level of comprehension and maybe current level of confidence in exercise. We can't just assume everybody's rip-roaring ready to crank out an exercise program, and we'll talk about that more. One of the big things that often gets thrown out there is, this whole when do biomechanics matter? And I take a lot of this from Greg Lehman's work. Biomechanics, if you're treating high-level athletes or folks that are lifting heavy loads, I work occasionally with nurses' aides who are doing a lot of the heavy work of nursing professions. Those patients or those folks are lifting, oftentimes completely dependent patients who are upwards of 200, 300, and sometimes more pounds. They better be using good mechanics to maximize their efficiency of those movements to help transfer patients. And they better train their body to be able to tolerate transferring 200 to 300 pound patients to be able to make sure their body is at a performance level to tolerate the loads that their job is asking of them. And I think to keep it simple, that's really what we're trying to do is can the patient accept the loads that their life or their valued activities are asking of their body? And if they can't, then design an exercise program to get them there. Do biomechanics matter when we're talking about, a 75-year-old person walking up a step? I think we got to be careful with nitpicking over genu valgum and Q angles and all these different things of biomechanic, analyses with some patients where they just need to desensitize it. And I like another one of the articles that Jared posted on the thread of discussion here was why Greg Lemon put strength on dysfunction. And I'm 100% with it. You'll see that these people can improve performance and the ability to get up and down steps. And there's no data to support we're changing a ton of, if any, biomechanical variable with them. They need to be able to load their movement patterns in a way that doesn't produce sensitivity or emerge a pain experience. But we can obviously tinker. We can create novel movements to desensitize the patient, where we kind of maybe have them move a little bit differently than they're not used to. That fires maybe different movement patterns and if neural signatures, if we want to get into Butler Mosley's thoughts, where it isn't as much kind of wired into that pain emergence as maybe other movement patterns are with the patient. Maybe there is a time where we avoid sensitive movements, or maybe we need to break up movement habits, piece by piece and put them back together to help a patient perform a movement better. So when we look at movement, and I think I've shown you this slide before, this is a great study. I think it was in one of your readings about Paul Hodges and Lorimer put this study out there that really looked at, a lot more of the complexity around movement than kind of what we had previously thought about. I think in my earlier trainings with spine stabilization and different things, it was all about Punjabi and the neutral zone and how well we were able to control the spinal segments around the neutral zone. And I'm not saying that's completely useless, but man, to really think one segment of the spine has agency over a massively complex experience, I think is pretty inaccurate. Of course, there are times where the patient might have something specifically, a specific back pain issue. We know that's much less common than we report or consider in the literature. But where we might need some more specific inputs at a specific area of the spine to help things along. But when we start getting the persistent pain where pain's lasting long past tissue healing times, we have to recognize that it's much more complex than a specific segment of the spine. Can we produce some good input through a specific segment of the spine that might be perceived by that patient to be the most comparable area of their spine to their pain experience and have a more or the best chance of changing their pain experience? I think yes. So I think there is times where maybe, being specific as far as trying to find the most sensitive area that the patient, perceives to be representative of their pain experience, depending on a lot of variables. We don't just go poking in their pain if they're highly central sensitized and, they have huge amounts of temporal summation, where the more we start nudging out, the pain gets worse and worse. But if they have, different signs and symptoms that make it where we can start getting in and nudging and modulating the pain at the site where they most are concerned about their symptoms or most representative of their symptoms, then I think we have the best chance of producing within session changes and as a result, some positive changes with our patients. But again, the intention of this slide is I'm not going to go into all this stuff, but just recognize it is really complex when we start talking about movement and what goes into, different movements. When we start looking at body schema and we look at, the representation of that body in space and cortical smudging and all the things we know that are happening in the central nervous system around pain, we got to look much more than just how a muscle is locally performing at the spine. Not saying we disregard how maybe a specific muscle is performing, but man, it's much more what dictates how that muscle functions is much more than just a local issue. And in the end, when we really strip it down to the bare bones, you're either calming things down or building things up, and we're either protecting or exposing. And patients often fall on these continuums where maybe, I think most of the folks I've talked to thus far in the mentorship, and definitely me early in my career, I would hang way too much on the left side of those continuums because I was paralyzed by this fear of tissues, because that's how we were trained. We had all these pain generators that we shouldn't be monkeying with. And now I am much, much more earlier able to work onto that right side of the continuum, get people exposing their tissues. But the key is making sure their beliefs and thoughts and cognitions around you exposing to that are on board with you. Because if you start exposing a knee-OA patient to load through their knee and they still have a bone-on-bone, crumbling knee narrative in their mind, chances are it ain't going to go well. So you need to make sure the patient's mindset is with you when you start doing exposure. And that's where pain neuroscience education and addressing maladaptive beliefs and behaviors and performing behavioral experiments to help people confront some of these maladaptive beliefs and confront themselves with their own strengths can be very powerful tools to help patients start getting themselves moving forward. This is one step below a Cochrane level review. This is Facebook, and I grabbed this from Exploring Pain Science, just a screenshot of Kathleen Sluka, who has written, is very highly involved in the International Association for the Study of Pain. She'll be presenting in Boston here next month, which I'm excited to go to. But she's probably one of the authorities in pain from a physical therapy profession aspect when it comes to, being an authority in the pain game from a international, interprofessional mode. But they had a discussion here around exercise, and she talks about how she's a strong proponent of exercise, but those effects don't last forever. If you stop, the benefits go away, and it is something that the person can do to themselves, so it gives them some internal locus of control. But she did, without dogging manual therapy too much, saying there is a time and a place for everything. That's the way you don't get, tomatoes thrown at you. And if you end up at the American Academy Ortho Manual PT conference, understanding how treatments work and what mechanisms are going on in your patient is critical and effective to effective individualized therapy. It's not one size fits all. Exercise can be a first line treatment in pain and should be. It's just what the definition of exercise we'll talk about. It really, and I'm not going to be able to get into all this today, but it does an amazing amount of things. I mean, from the things it can do from essential inhibitory pathways, from a top-down modulatory perspective, also decreasing that central excitation, reduces excitatory ion channels on nociceptors. So some of these peripheral, into these terminal ends of these nociceptors in the tissues, we're decreasing some of the excitatory ion channels on those nerve fibers. We promote anti-inflammatory immune system locally. We'll talk about how the muscle can release all kinds of groovy chemicals, both locally and systemically and centrally. That'll help with tissue healing and also reduce some of the psychological confounders such as pain, catastrophizing, depression, anxiety. I think when we start showing people they're capable of moving successfully, it is a very powerful psychological treatment. It's showing them that their thoughts and beliefs might not be correct and maybe forming some new thoughts and beliefs around their abilities, which can cause massive shifts. Phil and I talked before about some of the things where we can get people believing that, look at what I was able to do. Look, you were able to get me to do things I never thought I was able to do. There's some amazingly powerful psychological, physiological, chemical changes happening from a top-down perspective when you start massively shifting somebody's belief in themselves and you start giving them hope. That's a massive shifter in how their central nervous system modulates pain. And it can really make a massive change in depression, anxiety, and different things that might be seen strictly from a psychological domain. So let's talk about the muscle as an endocrine organ. And Rod Henderson is the one that really introduced me to this concept in one of his talks he did for us, probably about a year and a half ago. But some of the chemicals that these muscles secrete, cytokine, interleukin 6, and brain-derived neurotrophic factor. Look at what these things do. I mean, when we look at some of the studies and things, this is from Pertese et al. In 2013, but these are some pretty amazing effects that these chemicals can have in the body. And a lot of this probably makes sense when we can go out for a run and we feel like we're the most productive and cognitively sharp human out there with what we see with brain-derived BDNF factors and effects that it can have. So these chemicals can really do some amazing things, and unfortunately, when we fall off the exercise wagon and stop using our muscles, these kind of things go down, don't get released, and therefore we don't have as much of these type of effects going on in our body. Peterson in 2009 really looked at how this physical inactivity as a result can really go into a cascade of events that can really create a not well human, and it goes into abdominal adiposity and macrophage infiltration of visceral fat and chronic systemic inflammation, which can go into, and you talk about all these conditions about how atherosclerosis is now a systemic inflammatory condition. It's not really being seen as some sort of thing where cholesterol magically, decides to clump up around there. It's more of an inflammatory process that's going on due to a lot of these chemicals, cortisol and glucocorticoids that get trucked in the body when we're inactive and stressed. But read Robert Sapolsky's work on that as well, why zebras don't get ulcers, and it gives you an amazing way to start piecing together physical inactivity, stress, and some of these diseases we see here, cardiovascular disease, depression. There's some discussions on how it can affect cancer, where your cell division and different things can go bonkers, and some of that homeostatic function of being able to maintain appropriate numbers of cells and control division and things of cells, where cancer obviously is where that division of cells gets out of hand. Dementia, type 2 diabetes, all these things are terrible issues that we have in our society, and argue combination of physical inactivity and stressful lifestyles and stressful lives that people have to lead, especially when we're talking about low socioeconomic status and other things, that really doesn't really generate a lot of reason to have a lot of, that doesn't give a person a low stress environment. You can see how these things can all correlate with each other. The other thing I think we should be mindful of when we're exercising people is, sometimes we think of ourselves where, when we exercise, we feel freaking wonderful. We feel like, man, we could tackle the world. We feel like, I don't get the runner's high that much. I'm more of a Clydesdale approach with my running, but we can really have some powerful effects with endorphins and kephalins and serotonins, things that medications can't even touch from a level of potency coming out of our brain. But what we see with folks in persistent pain is those top-down mechanisms aren't there. This top-down pain off and positive pain inhibitory mechanisms just aren't there. If anything, it's pain facilitatory mechanisms. So they, if anything, get hyperalgesia after exercise. These are the patients, your fibromyalgia patients, or your chronic fatigues, or your others, maybe POTS patients who are just have systems that are highly sensitive to engagement. So, we have to be mindful that we can't assume that we pop everybody on a treadmill and they're going to have this wonderful response to exercise. We have to consider that, do they have some of these? And you can hear it in their history oftentimes. What's been your experience with exercise? Oh, I've tried and I'm in bed for 3 days. Or you hear people talk about all these miserable experiences that they've had with exercise. Then that should make us think that maybe this dysfunctional exercise-induced hypoalgesia isn't present. Kelly Noggle, I think, is a researcher that has done a lot of work on this whole exercise-induced hypoalgesia, which I'd highly recommend you look at her literature on that. Elizabeth Danon out of Joe Naze's group put together a great article, and I believe it's in your readings. If it's not, let me know and I'll throw it on the webpage for us. But some of this dysfunctional exercise-induced EIH during exercise might explain low exercise compliance. And if exercise has such a horrible history with somebody and they have this hyperalgesic response, pretty much makes sense why they're not going to be compliant with things. Yet when we don't consider these things and just assume, which I definitely did earlier in my career, that I throw exercises at patients, they're going to do them, and they're going to have a positive response to them. One, we know compliance with exercise, if we look at the research, is terrible. But we also need to understand that what is their system, what does exercise represent to them cognitively, and what's been their past experiences with it. And that should be something that you ask the patient specifically, and we'll talk about it when we get into cognition-targeted exercise. But this lower threshold for perceived nociceptive input following exercise, where when they do these studies, and it should show that, man, I can show higher pressure pain thresholds after exercise. These people have less pressure pain thresholds after exercise, which tells us there's almost a hyperalgesic or facilitatory mechanism going on with them. But some of the general guidelines they talk about exercise, not to exercise, and how to exercise with chronic pain. Aerobic exercise, from their perusal of the literature, seem to be better than eccentric or isometric work. And if you read the research and literature, isometric work has been shown to have some positive effects. But again, not a one-size-fits-all. I believe there were some recent studies around Achilles tendinopathy with isometric work, and it wasn't as good as we thought it was. But it's a more case-by-case, and apparently you have to do some trial and error with patients and see what's better. And we'll talk about kind of my approach with exercise as far as how I might approach things too. And then other things that might be helpful for patients. Some patients who have hyper, maybe they got a rotator cuff that's miserable, their shoulder, they have chronic neck and upper quarter pain, that maybe they would do better with a more aerobic program or non-painful regions of the body, getting them strong, releasing some of that good, chemicals from the central nervous system through exercise, and something they have confidence in that feels good to exercise. So using that from a pain modulatory perspective, where we're not necessarily going directly at the body part, could be a helpful approach with exercise with patients. But we have to consider, some people don't look at exercise with this rosy glass perspective. That might be more of a stressor. Sometimes it might be a schedule where this patient's got, they're a single parent, they're working 2 jobs, they're have all these crazy amounts of time demands on them, and that you're going to ask them to throw 20 minutes of cardiovascular exercise a few times a week in there. And I just think that's again, when you don't know the human in front of you, we just kind of assume that it's going to be some positive response. What's their mindset and how they view it? And that's just, again, what do you think about getting into a cardiovascular exercise program? Flat out with a patient. What do you think about strength exercise? What's your view of getting yourself into the gym or getting yourself more fit? And seeing where they are cognitively, what's their mindset around that? And if they're nowhere near it, then you might need to either start eliciting some, going into some motivational interviewing and finding out, okay, you have these goals of being able to do these activities, yet your lifestyle and activities and exercise and movement level is here, and you kind of show these discrepancies to the patient and try to show them and talk them into talking. So, well, I guess maybe it is not going to be realistic for me to expect me to meet these goals with my current behaviors and where I'm at from a behavior standpoint. But that's a challenging skill and an artful skill that you need to develop, is to be able to, not confrontationally get after a patient of, hey, you can't sit your ass on the couch and expect to go walk Costco without pain. I mean, that's maybe truthfully what we might be thinking, but structuring conversations in a non-confrontational way where patients can see that, hey, yes, sitting on my ass is not going to get me to in Costco. And most patients want nothing to do with sitting on their ass in the first place. That's kind of ridiculous that we assume that all patients would be lazy or any of that stuff. So, we just have to get patients to understand their current approach probably isn't going to be an approach to get them towards their goals. What would be some ways that they feel they can safely start an ability to engage themselves and get back into movements that move them towards their valued goals? The other piece of that article that I think is important that we should be considering with patients is recovery. What we assume is that everybody should be doing a couple times a day, 3 times a day, 3 sets of 10, all that generic exercise prescription garbage. Some patients need a day off between exercise, especially if they don't have homeostatic systems that have shown any ability to right the ship very quickly. The people that flare and are in misery for 3 days, probably I've already shown you that with activities, they don't really have a system that modulates itself down well. So you need to understand that recovery, what does that mean for somebody? How long does it usually take you to simmer things down? You hopefully know about their symptom behavior of what they've told you. Yeah, like I just said, if they said 3 days to calm down, then you know that recovery might take a little bit longer for them. So your exercise prescription might say, hey, as you start with this stuff, let's start getting you doing some activity, but I want you to take a day off between, focus on some of those things that we're going to also teach you today about things that quiet your system down, the breathing, the meditation, maybe some gentle yoga type stretching, where you give them some strategies to help their homeostatic systems quiet things down so you don't have to hopefully wait 3 days before they can exercise again. And recognize chronic pain patients struggle to keep a balance. And chronic pain patients in chronic pain, I should say, that's not patient first language. That's PT 101, and that's poor language on my part. Anyway, so you have to understand that where that person is, what their experiences are, what their viewpoint is, what their appraisal of exercise, all these things that are just simple questions that I think we often implicitly think we have an understanding of, but without asking, we don't know with patients. So education strategies, again, P&E to me is a way that you get people to understand that movement is safe to engage in. We just have to turn it down to a safe level that they can start working with the sensitivity of their system. Remember, this is sensitivity, not damage, and then also talking to them about how you can't get tolerant to the sun, living in the cave, as far as you're not going to, get stronger and be able to walk Costco or be able to play with your grandkids if your current activity level is what you're asking of your body. I mean, are you giving your body a reason to be able to perform the activity that you want it to perform? And I'll ask patients that. I say, based on what you've told me with your current activity level, you told me you are in your reclining chair, pretty much 8 hours a day. You occasionally go to your computer desk, and then you're back laying on the couch. And so that's what you're asking of your body. And your goals are to be able to have your body tolerate this. Do you think your current lifestyle and your current activity levels are asking your body to be able to perform that level of activity that your goals are? And most folks will say no, but shit, I've had horrible time with exercise. I've been flared. It's terrible. Exercise is terrible for me. And then you validate that. Yeah, you have had a horrible experience with exercise, but here's why I think that is, based on what we talked about with sensitivity versus damage. And you start getting people understand that, yes, if we race you into the gym and have you pounding on weights and blasting on a treadmill, you will fail with me, and I will be the next therapist to step in line and not do well with you. So let's look at a different approach that takes into account your unique sensitive system and start getting you on a path to success. And then you also set people up saying, hey, despite you and I trying to work very slow and steady and start at a very low level, you might still have a flare. And I don't really care for flares, but the good thing we know about them, you didn't damage yourself. You prepare them for the flare, and you prepare them that, hey, here's the strategies we're going to use. I want you to let me know when you use those strategies. Does that quiet things down a little bit more quickly than what you're used to in the past? Hopefully some of these homeostatic modulating strategies of meditation, breathing, basic general light stretching with, almost a yoga perspective can be powerful ways to modulate those autonomic systems down and those protective systems down. But again, you prepare them for those flares, you set them up for success, and if they don't find success, it's not that you failed. You've now the patient gets that flare, and they say, "Yep, Mark said this might happen. He also said that we're going to learn from it, and it gives us some good information. And here's what he told me I need to do with this. So I'm going to be able to, quiet this thing down hopefully more quickly and get back on the horse as quickly as possible." So identify specific movements that are limiting the patient. In the end, what if we could, Adrian will talk about, if I could flip a switch on your body today and take away all your pain, what would you get back to doing? What would be the first thing you'd want to get back to doing? I'll ask people, what are the things in your life that give you meaning, that give you purpose, that get you excited to get out of bed, that you're no longer able to do or not doing nearly as easily as you'd like to do, that we can help you get back to? And man, when you can start, that is the number one key I would say that I prescribe an exercise for people, that if you don't know that and you can't constantly be reflecting that back to a patient to show them, this is where we're headed, this is why we're doing what we're doing, that this is the goal that you've created, patient. I didn't throw this goal upon you. It's one that we partnered up to come up together. If you miss that piece, then your exercise are going to struggle, because they don't see where you're going. They don't see how this connects to their valued goals and their activities. So it's not going to be something that really has a lot of things that ring true for them or really tap into their inner drive, because they don't see how it relates to their life. And consistent strategies are important. Again, if you're working in a scenario where you're having PTAs or support staff working with exercise, then you better be training your aides, your technicians, your PTAs to be singing the same message around exercise. Because if you are talking about sensitivity versus damage, and then your PTA takes them to the gym and, oh my God, you have pain with that exercise, let's stop, and they start associating exercise with bad things, then they're just reinforcing and combating everything that you're trying to do well in treatment. And this comes from Joe Naze's work in 2014, a great article on altering pain memories through cognition targeted training, which is just basically, asking them explicitly, what is this particular exercise threatening for your back? Do you feel that exercise is useful for your recovery? Do you think this exercise is dangerous for you? What do you think will happen if you perform this exercise? So having those type of bits of information on board are massively helpful to help you understand where that patient's mindset is. And that's where I think pain neuroscience education and this whole pain science movement is. It's basically, let's try to understand what's going on in the central nervous system around your exercise, around your manual therapy, around everything we're doing. So the central nervous system, hopefully if it's not on board, we work to get it on board through adaptive beliefs and behaviors, so you can have a better outcome with these patients. And asking some of these questions in your examination or when you're starting to engage in treatment are crucial pieces of the puzzle. One of the other things they talk about is if you get into I'm forgetting his name, graded activity programs where you're starting to do very quota-based things, where you're having patients, where you're removing pain contingencies. And by removing pain contingencies, it's basically, if you tell people you can only exercise if it's pain-free, that everything is contingent on where their pain's at, then that is the wrong way to go. Obviously, we don't want patients blasting into their pain. But, when patients experience discomfort and sensitivity, say, yep, we're working at that sensitivity. You're sore, but you're safe. Let's nudge into it. Now, we also have to make a judgment, and I wish I could tell you there's an exact formula for that, of how much can they nudge in without flaring? And when they do have some sensitivity, how do we react as therapists? Because a lot of patients will tell you, I don't move, I can't have any movement. I don't have any movements in my repertoire that are pain-free. So there's going to be pain on board with every movement. So if you put a good mindset around it and good, hopefully, central nervous system that's going to be more in an inhibitory mode versus facilitatory mode, then you have a better chance of succeeding in them. But again, you have to remove pain contingencies. So you start setting, how much can they walk? How much time can they be on an exercise? Maybe you start doing length of time versus reps, or maybe you do reps to how much can you do before you start feeling like there's sensitivity going on. And it's not this 3 sets of 10 crap, unless 3 sets of 10 is challenging their loading capacity. Maybe it is, maybe that you find that you start trialing into an exercise and yeah, at 10 reps, they're starting to get challenged and they're starting to nudge into that sensitivity. Then 10 reps is what they start with. And then they move themselves forward slowly but steadily. Maybe they will start with 1 set of 10 and then work to 3 sets, or 3 sets of 15. But again, I think, what are the movement demands of their life? Maybe they need more of an endurance mode based on they want to walk a mile. Then you need to get into where their exercise starts working into endurance-based activities. So it doesn't need to be overly complex. Sometimes, during exercise too, a helpful thing that I've found is when we know these folks often have wind up or temporal summation, which is just this ramping up of input based on this consistent, the more input at a consistent frequency will ramp up the kind of action potential or outputs that are kind of magnifying function of the central nervous system at the dorsal horn. Or maybe if we go slower in frequency, we can decrease some of that temporal summations, because we let that, that kind of action potential wind back down, as opposed to just ramping and building and building and building. We give it a chance to calm, but we also help that central nervous system calm things back down through breathing and being relaxed with exercise. I think we'll talk a little bit about some of the ways we approach exercise with being in perfect form and tense and all this stuff. I don't think is helpful at all. And then how do we look at it from a progressive exercise standpoint? And then this, progression for a patient could be through an exposure progression, where it's feared movement progression, where we're taking that graded exposure approach that Corey Blickenstaff is such an expert at, where the load of that exercise isn't necessarily how much pounds it has, but how much it's activating these areas of the nervous system that are associated with fear, the amygdala, and all these areas that are churning out high levels of sensitivity due to past experiences and cognitions around fearful exercise. But if we can start loading the patient with a level of tolerated fear and that they can start engaging into and confronting themselves with their strength and disconfirming some of their expectations of damage after doing some of these fearful exercises or movements, that they can start building up a tolerance to those, where they build up a tolerance to some of these fear-based movements, that they're limitations that they've had. Of course, we can work in physically demanding conditions for the patient. Again, the big thing is we got to stop underloading patients and be much more willing, I think, earlier on to move people into the exposure and build it up phase, because we have to be mindful that the science is telling us that these tissues can have degenerative stuff going on, disc bulges and even herniations, and people can still engage in successful movement. We got to stop being fearful of movement ourselves as therapists and stop underloading and underdosing our patients. But also consider stressful situations. It's like, I always joke with patients, it's easy to, I get a lot of golfers in Phoenix. I'm like, you can be a good putter on a putting green with your buddies, but what happens when you're on the 18th green putting at the Masters to win your first major? Do you think there's a different nervous system going on if that was you on the putting green versus the 18th green at Augusta? Most folks are going to say, oh yeah, absolutely. And it's like you're performing the same movements, but your movement skills can change dramatically when stress is on board. And then maybe you can reflect back to patients how they've had past experiences that they've reported to you of how they perform poorly in stress or different things. So not necessarily from a performance, from an athletic skill perspective, although it could be if you're in that kind of population, but maybe just how movements can be much more painful and sensitive when they're having stress and engaged. So stress could be another load that we add to a patient. I'm not going to read all this stuff, but this Booth study, Lorimer Moseley was a part of it, and I think a lot of people, I'm not this type of therapist, and I'm not saying it's wrong to be different than me, of course, because we can all have success with different approaches, but Booth had all kind of laid out, some of the ways to structure aerobic exercise. When we talk about dosing, here's a little bit more of and this is based on a systematic review, I believe, of exercise studies out there that they looked at, well, with chronic pain patients, what can be the ideal frequency, intensity, time type progression of aerobic exercise. So we'll talk with, ratings of perceived exertion levels and how long, we're talking less than 20 minutes with exercise tolerance up to 60 minutes. You can consider shorter intervals. There's a lot of different ways we can tweak it. I tend to just use different approaches that we'll talk about here at the end. When we start talking about resistance exercise, I don't get into a ton of calculating 1RM stuff. Just with my patients, it's not really realistic. But and if others do, I'd love to hear how you're doing it and how you find it successful. So again, I'm not finding that is just my perspective, not the only way to look at it. I just what are the loads the patient needs to perform in life? Where are their load tolerance right now? Through some trial of let's start small and find out what they can do, and then let's build a program to move you to the loads that your life is going to ask. If you need to tolerate loading your knee to step up a step and lift, whatever 175 pounds of your body weight up a step from a single leg perspective, then I need to build strength in the muscles that perform that activity. It doesn't need to be fancy, but I need to understand that there's cognitive or cognition related loads that might be contributing to the sensitivity of that movement. So I might need to address those, along with, nociceptive tissue loading, specific things at the tissue level that are sensitive that I need to understand and load at a level that their tissues can become less sensitive to. But also being okay to nudge into some sensitivity with that. And, the surprising thing is, as I've exercised into sensitivity with some patients who have, based on their exam and everything, have showed me that this is definitely more of a sensitivity thing, that the quicker you start nudging these people and exposing them into it, man, they make some big shifts because you're really showing them and confronting them with their strength in a way that they didn't think they were capable of doing. And man, when that central nervous system makes a huge shift on descending inhibition versus facilitation and confidence and hope and resilience, it can make a major difference in how they perform in a short period of time, which when we read some of the studies on how long it takes to make muscle changes and in true strength changes, we know we can't make those changes as quickly as we sometimes see them in clinic. So that's kind of where I stand with that. And this is something I've borrowed from my good buddy, Ben Cormack. And Jared and him had a nice little video there on the live stream that they did a few weeks ago, I believe. But there's a lot more to think about around exercise than just simply tissue capacity, which is, I think, where we tended to park ourselves. We can't assume people are adhering to our exercises. So making it meaningful, fun, understanding what their perception of exercise is, like we said, with cognition targeted exercise, and understanding where their mindset is. What's their preferred mode of exercise? It shouldn't be shoving people into our preferred mode of exercise. You should be shoving fitting our exercises to what their preferred mode of exercise is. And then understanding whether things are adaptive or maladaptive, high or low variability, or just the way they move. Belief structure, we've already talked about that. What is their past experiences and beliefs around exercise? We might need to work with them on that. As I kind of think about things a little bit more too, think about how we prescribe exercise. And, we get all these people where, and I'm just reflecting back on how I used to exercise, we know pain is protective. So we know these people often don't move variably. They're very invariable. They're very often tense. Yet how do we coach exercise? It's often keep your head over your shoulder, scapula back, only move a certain, we educate people on exercises in ways that gives them no reason to move less tensely or less protectively. We almost feed into that protective by coaching them up on all these rigid rules of position and tension and posture that I've really broken away from a lot of that stuff. I've gotten people just, let's lift your arm with a 1 pound weight, like you're putting your plate up on the high shelf, or, so I've gotten away a lot of those rigid movement pattern stuff that oftentimes, if we think about, okay, pain is protection, we're making somebody tense the heck out of themselves to establish this proper position of an exercise. I just think that's not the most effective way to go about it when it comes to helping people become less sensitive to exercise. I think having people move and focusing just as much on that concentric, engaging phase versus the relaxation phase, and making sure people, what's their autonomic system and what's they're doing. We have some windows in it. How are they breathing? Where's their tension level? See some of those things going on. What's their facial expressions look like? If somebody's like this when they're exercising, my God, they're probably engaging things. We got to get them to start becoming thoughtless, fearless movement. And if you think about how we move prior to pain, and then how we coach people to move in the clinic with all this rigid tension, rules, form, posture stuff, it doesn't make sense to me. And if the more I read about pain and how motor systems change with pain, it doesn't make sense to me to exercise so rigidly with stuff. Now, when we're talking performance settings and with athletes and with high load situations, again, maybe we do need to coach on specific ways to help people maximize performance of their lifting, minimize loads on certain structures that we know probably repetitively lifting and loading with heavy weights isn't going to be an effective way of going at it. Let me just bring up the, where are we here? Let me just bring up, okay. So let's look at, I just wanted to look at some of the things we had on questions here as far as strength being a physical construct. I think strength is much more than a physical construct. I think manual muscle tests, I don't find them to be very useful much at all. It basically tells me how confident is someone to load their arm or their body part against my resistance. It can give me some ideas of sensitivity and stuff, but we know there's so much more to sensitivity than just what's happening at the tissue level. Now, of course, if there's signs of a specific tissue-related issue, a tendinopathy or something, then I get some windows in on how sensitive their tissues are to load. But I mean, to get really picky and nitpicky about grading things so specifically on a manual muscle test scale, I'm not sure that's really as important as we thought it was. But so strength, I think, is much more than a physical construct. There's a lot of cognitive and central nervous system related things that elicits how well our body is willing to exert force against load, and there's much more than just the force capacity or the sarcomere length or any of the local muscle factors that we traditionally kind of focus ourselves on with that. Muscle imbalances, Amy asked about. I've really let go a lot of that stuff. Vladimir Janda and the lower cross upper cross syndrome. I think there's definite habitual ways we load our tissues from the forward head position. I think you'll see some people that get regular lower cervical related, radiculopathies that we can specifically identify with, neurologic testing and things, or where we can specifically change symptoms with unloading sensitive areas from habitual positions and movements that people have. So I think there might be something to creating some movement variability around habitual movement patterns and unloading tissues that are getting loaded chronically in ways. But again, you got to validate that with your patient and not just make that a blanket rule that everybody must follow, because that's ridiculous. And show that if you do some things that create, an addressing of a supposed upper cross syndrome or something, that it, one, modulates their symptoms positively, and two, it doesn't require your presence there to modulate it in the future. And we don't put any I don't tell people they have muscle imbalances. They have sensitivity to certain positions or loads, and we're going to protect it, and then eventually you need to desensitize yourself to that load. And if your life is lived in a load, you need to break out of it ever so often. I think that's where folks that where sitting may become an issue, if that's where they're in constantly in a flexion load at their low back. No tissue likes to be loaded the same way over and over again. There's pretty decent amount of biomechanical studies that show that that's not necessarily the most helpful way to go about it. Let's see, Dan Morris, can't go wrong getting strong. In a way, I get the gist behind that. I know you said that jokingly. But I think there's sometimes we get a little bit too fired up with that approach and just think that everybody needs to be doing deadlifts and going into CrossFit and all that stuff. I think if that is something that, gains confidence in the patient's got good cognitions and thoughts around it, there's a lot more variables to where I would get somebody into that versus just assuming everybody needs to get into that approach. Amy had asked about manual muscle testing, and I think hopefully I covered that, but definitely throw some more questions out there if there are any. Jared answered a few of these, so thank you, Jared. Strength training, I think there is a graded exposure component to it as far as strength training changes, take time. Can happen, but a central nervous system that's confident to load, that's on board from a central nervous system perspective is going to be, I think, have much more rapid strength gains than one that's still fearful to load, that feels like or maybe there is some tissue issues that are shooting in danger that are causing that central nervous system to not confidently load that body part. So maybe we do need to protect a specific tissue issue. We can't just assume it's all a central mediated weakness type thing too, because there are tendinopathies and, although even the tendinopathy research is interesting as they're starting to look at central mediated things that relate to tendinopathies. But yeah, it's a balance. So hopefully that didn't muddy things up for you guys too much. But exercise, one of the other concepts I'll leave you with is this kind of Goldilocks principle that I think is what Adam Meekins called it. It's kind of how I practice. But, when you get into, somebody who needs to exercise or achieve better movement in their life, make sure you tap into what their valued goals are, that what are the important movements that they want to get back to, that they find value in and want to get back to. If they can't find any value or anything they want to get back to, then that's probably a psychosocial barrier that you have to tap into, because if there's a huge amount of depression and sedentarism and stuff that you're trying to get someone to exercise who has zero interest of becoming a mobile, active human, then maybe they need to find a way to tap into some, and maybe that's through psychology services as well, that they need to start finding some meaning and purpose in life that gets them off the chair, off the couch, to get moving again. But anyway, if you find that movement that brings value and meaning to them or purpose, you find it. You try to find what's their load, where are they at capacity-wise in the loads that movement demands of them. So and that might be some manual muscle testing or some load testing of specific muscle groups to find out where they're at. But it's also what if they can't do sit to stands? Maybe I raise the plinth up. What's a sit to stand they can perform now without lighting up their knee or their back or whatever? And that's the starting point when we start doing sit to stands as their exercise, which often it is for me. And we just design loads to get them to perform what their valued goals are. I don't think it needs to. And then, I purposely start light, load them to where they feel like they can be successful. They might get a little sore, but they don't get a massive flare. Like I said earlier, you prepare them for a flare so they know it doesn't mean that you've created more bone on bone. And then you progress them upwards and you start confronting them with their strength. You identify things that might be fear related and you engage them in maybe an exposure-based approach, maybe through some formal behavioral experiments or formal exposure-based treatments. And then you continue to load them. Maybe you're also loading them from a cognitive level of fear. You're loading their amygdala to be able to tolerate and not be fearful of it. So you take some of that exposure-based treatments and look at that as a load to the system as well. So I'll leave you guys with that, and hopefully that gives you some ideas of how to kind of throw some exercises at your patients and have some success with it. Let me know what you guys think, what questions you still have out there. We'll make sure we touch upon them, and have a good rest of your weekend.